Hello, and welcome to the Emlyns Podcast. I'm Simon Carley.
I'm Ashley Leibig.
I'm Natalie May, and this is our very special guest, Libby Hanrahan. Libby, tell us a little bit about who you are and what you do.
I currently work as a critical care paramedic for Sydney HEMS. Surprise, surprise. I've been with ambulance for coming up to 20 years, 5 years with HEMS.
Awesome. And you are a paramedic educator?
Paramedic educator within Sydney HEMS, yep.
Excellent. So, Simon, what are we going to talk about today?
Well, I thought we'd take a little bit of a pause, really. I wasn't here this morning, but I've been following along online, and I was lucky enough to come here around about lunchtime and see the presentations. And SMACCFORCE is an amazing conference. We hear lots of really interesting things. There's really incredible ideas here, and some of it is kind of like a little bit futuristic, guys. It's not happening in my place. Some of it's really cool. And what I thought we should address is how do we take all the stuff that we learn at a conference like this, the ideas, the inspiration, the thoughts, how do we actually make that happen on the ground? So I guess you come from different tribes, different organizations. We've had lots of experience in different cultures. You've worked in the UK, Australia. You've worked in New South Wales. Where else?
It's all New South Wales for me, yeah.
Oh, it's a big place. Actually, if you're from Texas, which is a long way away.
Yes.
Good.
Just Texas.
Just Texas, okay. Fine. The point is, we have different experiences. When you look at a conference like this, where do you see the challenges of taking the learning, the innovation, the ideas from here and actually making it happen for patients on the ground?
So I think that we have a bit of a mountain, I guess, to overcome when we get home, because every time I come home from a conference, I've learned new education, I go back and I want to tell my colleagues, oh, I learned this amazing thing, this is so great, and I am often met with well, that's not how we do it, or there's no way that'll ever work here, or we tried that once before, not going to happen.
So how do you go about addressing those issues? Because I think we were talking earlier, weren't we, saying that the similar sort of things when you go into a culture, and particularly when you're talking between different tribes, so the paramedics coming and telling the doctors what to do, or suggesting, should I say, or the nurses speaking to the doctors and things like that, you can have different cultural barriers that affect this in the workplace?
I think I'm probably one of the very, very fortunate ones in that within Sydney HEMS, we have a very, very pro-learning, adopting new learning systems in place, and they're quite robust. But then if I look at wider ambulance, and if we look at the 20 years that I've been an AMBO, for 15 of those, I wasn't within HEMS, and we've only just become a profession within Australia. And we've been really organisationally reliant upon our teaching, our learning, our professional development. And this format, this forum for us to learn, really wasn't or isn't, because I think it's still current, the place that we go. And so I think it's going to be such a new concept for us as paramedics, now that we're a profession, now that we have to look external to the organisation for our learning, for our professional development, for our growth. And I think that realistically, the cohort within HEMS is probably where that needs to be driven from, because we are so beautifully supported within HEMS by the team that's directly around us. How do we then disseminate that to several thousand AMBOs across New South Wales, across Australia? I don't actually have the answer, but I know that we're going to be an integral part of it.
I think one of the strengths that we have at Sydney HEMS and one of the strengths we have at the table is that we can take education forward from this forum in a multi-professional sense. So a lot of the education we do at Sydney HEMS is using the flight crew's expertise, so the pilots and the air crewmen and the doctors and the paramedics all work together to bring their own information and to share their knowledge and learning, just like around the table we've got a doctor, a paramedic and a flight nurse who all work in pre-hospital care. That's how it should be, and we should all be having that conversation internationally together. And I think technology in the future is going to help us to do that. That's going to make us stronger as a community and help us to take our ideas out there.
But of course, when we look at the audience here and we think about the people who are following online, this is preaching to the converted to some extent, in that these are the people who are terribly excited. And we have to recognise that in all our professions, there are people who are innovators, early adopters, and that tends to be this group of people. But there are also normal people, and they're not necessarily like us.
Just called you weird.
I take that as a compliment.
Yeah, absolutely, it is a compliment. But there are skeptics out there, and we love skeptics, as John Hines taught us. And there are also naysayers, and there are people who struggle to go with the adoption. I'm just thinking, in your experience, have you had the opportunity to say, this is something we should be doing in our practice, you've taken it back and you've managed to get it into service with difficulty or with problems, and how have you overcome that sort of thing?
For me, I think that that's a lot of seeking out some champions in the organization. So organizational champions to carry forth ideas or innovation, whether it's the leadership or it's informal leaders, and going forward with a dynamic plan that has not just I just want to do this thing, but has the actual research behind why we want to do this thing and what the potential outcomes and goals of that thing are, to present to leadership, and then get champions on board to bring people around. It takes a little bit of convincing. I was talking earlier, I'm also very involved in nurse-led ACLS and team resuscitation. And I was talking to some folks here from a rural hospital in Australia, and they were saying that they were able to take that same initiative and design it a little bit differently and curtail for what they needed to have in their organization, based off a podcast that they had learned about. And it took them a long time to get the physicians to come on board and the nurses to come on board because they felt insecure. So putting people into their comfort zone and giving them the opportunity to say, we will do this thing together and feel very protected, is a great opportunity to forward your message.
So I'll give you an example. It's not necessarily a clinical example, but it's the one that we worked on back in Manchester, about instituting in situ sim, which was something that we as the medical cohort thought, we're going to do in situ sim, it's going to be fantastic, it's going to be brilliant. And what we realized very early on is that the reasons why we wanted to do that were not necessarily the same reasons as other members of the team. And so when you talk about champions, what we've had to do is find a champion in management and explain to them and get them to value it. So we went to the management team and said, this is a system where we can potentially reduce the number of critical incidents that we have in the department. And then we went to the senior nurses, and we went to the senior nurses and said, look, at the moment in the UK system, you don't get education. You're not getting the teaching sessions that the doctors are getting. We can do this, and we can do this all together. It means your cohort of people will be getting this training. Now, several years down the line, it's being driven predominantly by the nursing teams who are making this happen because they've adopted it against their values. Now, that sounds a little bit tribal, it's us, them, and different ideas, but the point is that when we developed it, you have to get into everybody's head and understand what's in it for them. And then when you can understand that, you can play with it and make it happen. And I think that applies for clinical stuff as well as educational. And also that's a way of moving the things that you find here into the workplace. So if you're going to talk eCPR, you have to then think, what does that mean for all the members of our team?
I think following on from that, something I've learned in the last 3 years since I came to Australia is to be humble. So I actually counted up, I've worked in 8 new workplaces in the last almost 4 years.
Not because she's gotten fired.
No, many of them, actually 9, many of them still employ me. And that's really challenging when you're a senior clinician and you're walking in as somebody who is brand new, and I've had people challenge me and say, like, do you know what you're doing, kind of thing. That's confronting coming from a department where I'd worked for a long time and I knew everybody. And that constant change just teaches you again and again that you have to be humble and gentle, and I think that's the way to affect change rather than to go in all guns blazing. So it's a really important lesson to learn.
So I think that also brings up a really good point to start slow and small. We can't all go back to our institutions and pull off an attack sort of simulation, right? Not all of us can turn train cars sideways. But what we can do, and what I've been able to do with my team in our BLS, ILS, and ALS fire departments, is to introduce them for the very first time to live human patient simulation. Really simple. A drug overdose. We put someone in the bathroom. We have the iSimulate monitor. We have them knelt over, and we have a live patient doing this. And I will tell you guys, in something that's so simple, in a simulation that takes 10 minutes, just them having to move the patient onto a device to move them out of the room, just having them to be mindful of not flopping a plastic mannequin all over the place and talking to a patient and doing an assessment like they would if a patient could talk back to them. Those kinds of things, really tiny things, make a massive difference in that education.
Okay, so lots of things to think about there. I want to move us on to another little topic now and think about, this is me, I'm not a pre-hospitalist, as you know, or haven't been for many years, and I often look at you guys and say a lot of your practice is out there in the field, and you're often working with relatively small teams. It must be quite challenging to know whether you're doing a good job, how you're performing, and also, as if I was a senior clinician in those systems, how would I know how well you're performing in the field? How do you get feedback, and how do we calibrate and ensure that things are going well? Because that's kind of this interface between clinical care and education where I think there can be some really good wins. So how do you manage to do that, and how could people here do that in the future?
I 100% trust Libby to tell me when she thinks I've done something that is a dick move.
Yeah.
And she's done it. One of the many things that I love about Libby, and Libby's an amazing role model, is that she has this wonderful way of challenging you when she thinks that she knows that you're doing something crazy. So I remember distinctly on one of our first jobs together, she was like, "Hey, Nat, have you seen that end title? Are you good with that?" And I was like, yeah, that's fine. And I was like, oh, no, that's not fine, thank you. Yeah, and it just having that relationship within your team and building that where you trust each other, that's, again, coming back to the culture of the organisation, but trusting each other and being open is key to working together.
But how do you make that happen? So this is a question really of culture. Because that fundamentally, you see good organisations do that, and actually a lot of pre-hospital services, I suspect, probably do, at the high level. But how do we get that kind of culture embedded so that people have that ability to be honest and open? It's a challenge.
I think, particularly as an ambulance officer, we use really derogatory terminology. We're baggy-ass ambos, we're just the ambo, I'm the driver. And it's only since I've come to HEMS and started working within a medical team, I've consciously had to turn that around. I am worthy of the position that I'm in. I am worthy of the knowledge, the learning, the teaching, the investment that has been put into me. And I need to have an internal barometer and self-checks to say, I know what I know, and I know it well, and I'm expected to perform to that level. And if it doesn't feel right, well, then I need to put my hand up to the rest of my team and say, hang on, I think I'm out of my depth. And I would expect them to say that to me. But that self-worth and that self-trust that you have an incredible foundation of knowledge, learning, teaching. You need to step up to the investment that has been made into you. I think that is such a huge part of the teaching and the learning that everyone needs to have and be afforded.
So part of our education as teams should be about understanding values and scope of practice and how we work in that professional manner.
Absolutely.
And how we communicate to each other, Simon. Just to get your point across, doesn't necessarily mean you have to be a dick, right? I mean, we're not allowed to swear on the St. Emlyns podcast, so I'm just using this opportunity. But I think that when we're communicating with one another, and I agree 100% in the pride, but when we're communicating with one another, we have to be really mindful of that approach and how we practice that. We talk to each other in a very different sort of way at work than we would talk to our spouse or our friends. And I think that direct communication and honest is really important, but we don't have to be ugly about it.
Can I just ask one about interfaces? Because this is something that comes up a lot with our pre-hospital hospital services, is that the pre-hospital services would deliver a patient to hospital, hopefully, because they're still alive. And then in a lot of systems, they don't find out what happens. And you don't get that feedback loop and understanding. Now, again, HEMS services tend to follow these cases up. But the guys on the road back in Manchester often find nothing out about the patients. I'm just wondering whether you've seen any good ideas about how we can close those loops, because that's where learning happens. Case-based learning is really important, as is things like this.
Yeah, the operations that we tend to work in, they have a manager, a duty manager, who will be overseeing that, whatever that case is, and we try to make it available for the team that we've interacted with on the road to get information through us. But I know that back in the UK, there's a lot of emergency departments starting feedback conversations with road crews, encouraging them to come and say, hey, this patient I brought in the other day, how did they go? What happened? What was the diagnosis? Was it pulmonary edema or was it a lower respiratory tract infection? And I think that's really important. I think it's as important as doctors who work in emergency departments having an idea what it's like and how hard it is to do the work we do outside of a hospital. I think it's also important that we have an ongoing dialogue with the people who are bringing patients in, and likewise the people we're giving patients to, and that dialogue is kept respectful.
So, with 22 seconds to go, just to summarise, I think the messages we were trying to get across here is that having spent time in research and innovation and education in places like this, I think we've all come to the appreciation that it's not just about us. It's about how we get those messages out to the people who don't have the opportunity due to time, due to finance, because somebody's doing our jobs now whilst we're here. How do we engage them in those conversations? How do we help them understand and learn what we've learned? And some of that's based in culture. And actually lowering the hierarchies, talking to each other and showing each other respect is probably an easy win. I say easy, it's something we can all attempt to do, and it'll take time, but that is the future. Thank you very much for your time. And we'll see you again on the podcast.
So this is SMAC News presenting from the St. Emlyns. Okay, apparently I'm in trouble.
Yeah, I just don't want to be blocking all of you.
So this is SMAC News reporting from the St. Emlyns, home ground.
Where's that, in Worcester?
Yeah, Worcester.
Yeah.
Okay, so I think a very important note that was made there is we are very privileged to be able to come to conferences like this and to hear from the greats on what is new, what is happening, what is the sharp end of clinical medicine in our arena. What is Sydney HEMS doing? What is London HEMS doing? But unfortunately, the guy sitting back in, and my reference point is South Africa, the guy sitting back in South Africa, 300 kilometers away from his closest manager, never actually sees what's happening. He doesn't have access to Wi-Fi. He sometimes only works on a...
Or she.
He sometimes only works on a phone.
They're going to fight later.
Easy now. He sometimes only works on a phone that's got limited data. How does he listen to the high make podcast that happens? In fact, does he even know it exists? Is more the question. Something that we found works very well of late is to try and interact more with these guys. What they do have access to, find out what they do have access to, and send them the information in that medium. So actually downloading a podcast off St. Emlyns and putting it on a flash disk and sending it through to them that they can plug into their work computer and listen to. This way we can disseminate this knowledge to them. We can show them what we've learned in a privileged environment that we're in. And then also, so that's one-way communication. We need to have that feedback loop that comes back from our practitioners, comes back from the guys that can't be here. Africa's Twitter at the moment is WhatsApp. Okay, you can have much better conversations on WhatsApp, trust me. I've done Twitter for a while, and WhatsApp is still better. Have conversations with the guys that can't be here. Don't just always stick to the one group that's got access to the Twitter messaging group. Okay, make a bigger group. Involve people that's not currently involved, and show them that we care about their practice. In that way, we're able to give information, take back information, and give them the correct information that they need to go further in their clinical practice.
So could I ask people here to make a personal commitment to say that in a month's time that you can put your hand on your heart and say, I took the lessons which I learned at SMACCFORCE and I shared it with at least 10 people. Can you do that? Because that'll make a difference. If you can amplify what you've learned here 10 times, face to face, that can make a real difference. Thank you very much.
Thank you.